I arrived in this hospital in 2002 and I started working as a director of cardiothoracic and vascular anesthesia and intensive care, which means that I take care of patients suffering from cardiac and respiratory disease, both from a surgical and a medical perspective. Along with the clinical work, I've been also doing clinical research, specifically in the field of sepsis and septic shock, with a specific focus on the hemodynamic alteration and on the pathophysiology of shock. What happens in sepsis is that we have the guidelines, the recommendations define it as a dysregulated, I would say an exaggerated body response to an infection. And the serious aspect of all this is that this huge response may cause organ dysfunction in the septic patient. So the symptoms a patient usually shows when he or she is septic range from chills and warm skin temperature to maybe confusion, tachycardia, because the heartbeat is very fast in that condition, and they can also show rash on the skin. When the patient experiences a septic shock, which is a worse clinical scenario compared to sepsis, and it is defined as a subset of sepsis with a deep hemodynamic abnormality, the signs and symptoms related to the organ dysfunction are even worse. So it's both sepsis and septic shock are quite challenging clinical conditions to the physicians because the symptoms may be aspecific, but the patient is really at risk of death, and then the diagnosis should be very quick and very early. It's important that everybody understands that sepsis starts from an infection that can set off in any place in the body. And so sepsis can be considered, let's say, the second stage following an infection. And when sepsis steps into a more severe abnormality in cardiovascular, in general, in organ function, the patient is in what we call septic shock. So infection, sepsis, and septic shock cover the entire spectrum of this syndrome, and we should try to do any effort to get a diagnosis at the very early stage, because sepsis increases mortality and septic shock increases it even more. We have patients arriving in the emergency department with a septic syndrome, and then their clinical pathway starts in the emergency department where all the first measures, the first treatments are applied, because we, as I already said, we need to be very early in diagnosis and treatment. But sepsis can also hit a patient who is in hospital, maybe in a surgical ward or in a medical ward. And this will, of course, change the pathway, because these patients needs to have their sepsis diagnosed on the ward for a quick and immediate treatment. When the septic patient starts showing organ dysfunction, the patient needs to be aggressively treated, and very often these patients are admitted to the intensive care. And then the intensive care unit is the place where these patients can receive advanced monitoring and treatments consisting in particular in aggressive hemodynamic resuscitation, also with drugs, to allow blood pressure to maintain a pretty normal value and the perfusion to the organs to be adequate. in the very early stage of sepsis, the specific treatment of sepsis, which is antibiotics, that need to be given very, very early, so to prevent sepsis from going forward maybe into septic shock. And at the same time, we have to support the patient to maintain the organ function, to maintain the blood pressure, which usually in these patients tends to go down. And to do this, what is recommended to use is, as a first-line treatment, volume fluid administration should be given very aggressively and from a very early phase. And when the fluid administration does not restore blood pressure, then vasopressors should always be given to maintain blood pressure. In case a vasopressor administration is not enough, a second vasopressor can be administered. And in a very extreme situation, inotropes, which are drugs that support the heart. You asked me, how do you infuse these drugs, peripherally or centrally? So what is recommended is to start through a peripheral vascular access, to be very quick and very early in the treatment. But when the patient is then stabilized and the first treatments have been given, then we may go for a central line, which allows us not only to give the vasopressors and the inotropes, but also to do other monitoring and other measures. So it's very important to try to do any effort to prevent sepsis from getting into septic shock. Now, what is very important here is to try to have a very early identification of sepsis. And of course, also the aggressive initial treatment with antibiotics and the hemodynamic resuscitation I summarized for you are very important also to prevent sepsis from precipitating into a shock state. It is also recommended to monitor the patient during these early treatments, and of course also maintaining blood pressure is very important. I would say it's paramount also to prevent a septic shock to develop. In the recommendations, it is recommended to maintain mean arterial pressure. So in summary, it is very important to have an early diagnosis, a very early identification, and an aggressive treatment to prevent septic shock. The WHO estimates that in 2020, so the last update was only a few years ago, close to 50 million cases of sepsis worldwide were registered, and 11 million sepsis-related deaths occurred worldwide. So huge numbers. And I think that there is another number that we should think about. Half of these numbers of the estimated septic cases occurred in children younger than 5 years old. So you asked me if sepsis can occur in infants and children, in neonates. Yes, definitely. I think that linked to these numbers, there is also another aspect that in the times we are living we should not neglect: the costs associated to sepsis. The average cost of a septic case is around 30,000 euros in high-income countries. I mean, it's very important that we, of course, keep an eye on the clinical aspects, but we should always be aware as citizens of the numbers related to this disease worldwide. From my research, what I've learned is that septic patients show a very heterogeneous clinical picture. Every septic patient is different. And what is also probably even more challenging for us is that septic patients show an heterogeneous response to the treatment. As you were addressing, I try to tailor the treatment, and this means that you really need to measure a lot. You need to measure a lot in your patient, from the lab numbers, from the hemodynamic numbers, etc. And a continuous reassessment of the patient is needed to understand whether the patient is responding to the treatment the way you would like the patient to respond, or different approaches are needed. It's very important to personalize the approach in this setting. And in fact, I think that this is the main reason why most of the recommendations are weak recommendations and the level of evidence is low. Probably the most important things that we can do on a daily basis are to have and to apply sepsis protocols in hospitals, and hospitals have such protocols. And these protocols should also not only include the measures that we all know, like washing your hands, which is the first important message, okay? But also these protocols should include screening for acutely ill patients. But there is also something more that we can do. For example, we should remove urinary catheters where they are no longer needed. We should remove them from our patients because they expose the patient to the risk of sepsis. And then also, last but not least, we should have a very high understanding of the importance of using antibiotics only when they are needed. Because a real problem we have nowadays worldwide is the so-called antibiotic resistance, which is a consequence also of an abuse of antibiotics. And if you think that we have new germs, multi-resistant germs on the scene nowadays, more and more on the scene, the antibiotic resistance is something that we should consider very seriously. Well, as a final message, I would underline maybe two or 3 points. The first is that we should always have a very high level of suspicion for sepsis, because as I said, it is very insidious sometimes and symptoms are very aspecific. We also need to screen patients for sepsis. This is something very, very important. And when we identify a patient as septic, we should be very aggressive and quick in the treatment. The second point I would like to underline is that we as physicians, as healthcare professionals, should do any effort to personalize the treatment. And the last point, which has more to do with the communication about sepsis, explaining what sepsis is, what it means, because this is the only way we have to make people aware about sepsis and to have people ready to respond to sepsis and to apply what is recommended to do to us as physicians and nurses, but also to the general community in terms of prevention, for example, of infection, wash your hands, and all the things that we learned also during the recent pandemic. So really, my last message is we should try to communicate about sepsis every day at any level.